And our first resource person would be Dr. Nishani Lucas, consultant neonatologist. The topic will be tackling common neonatal challenges in first contact. And the second session will be conducted by Professor Pujitha Wickramasinghe, consultant pediatrician, on nourishing futures, fostering pediatric growth. Chairpersons, over to you.
Okay, good afternoon. This lecture will be conducted by Dr. Nishani Lucas. She is the first internationally board-certified lactation consultant in Sri Lanka. She gave her expertise to formulate WHO guidelines on counseling women to improve breastfeeding practices in 2018 and to the UNICEF to update and edit 2020 national guidelines for newborn care in Sri Lanka. Dr. Nishani has been a postgraduate trainer since 2013 for MD Neonatology and a member of the Technical Advisory Committee on Newborn and Child Health Sri Lanka. She is currently a senior lecturer and consultant neonatologist at the University of Unity Soisa Hospital, Colombo. I welcome you.
First of all, thank you very much for the kind invitation to be here. I would like to thank the President, Council, and also Dr. Marsh, who I knew from before, for giving this opportunity. So the topic I was given today was tackling newborn problems or neonatal problems in first contact care. Next slide. Oh, I can do it this. Okay. Right, okay. So I think it's important to perform a newborn assessment for all neonates presenting to first contact care, irrespective of what the presenting complaint is. And of course, no need to say wash hands, and wash hands before touching a young infant or a neonate. Video. So when we see a neonate, before we sort of lay our hands on it, it's important to inspect. So I'll just briefly go through the examination, the color in the palm, soles, lips. Look at the respiration, count the respiratory rate. Is it between 30 and 60? Look for recessions, as well as look at the posture and movement. Then we undress the baby. So it's important to go in some sort of order, otherwise we are going to miss because there are loads of things to be done with neonatal examination. Make a sound play karana. Palaveni sound. Okay, so there are different murmurs that can be heard. Okay, come on, it's okay. So when we examine the neonate, to auscultate, we can't go through the normal procedure like that we go for adults or for children because they are small and they are going to start crying soon. So once you undress, it's important to auscultate them quickly and effectively so that we get what we want and we don't upset them either. So it's best to auscultate them in the left sternal edge, sort of, our stethoscopes are quite big. So when you keep them, you should be able to hear either AST murmurs with ejection systolic murmur or a VST murmur, and in the left infraclavicular area. So just two places. And if the baby is still cooperative, go on to the axilla where you can auscultate, where you can listen for equal air entry. So then we move on to palpating the abdomen. Look for the liver, spleen, palatable kidneys. Look at the umbilicus. This is the only time in life when you have to look at it. Look for pus, blood, and periumbilical erythema. Put on the shirt, remove the nappy. So it's important not to take off all the clothes of the baby because they are going to get very cold and very uncomfortable. So one at a time. So we remove the nappy, and if it's a boy, we have to check for undescended testes, as well as look at the urethra for epispadias, hypospadias, and in a girl, we should check for ambiguous genitalia. Because this is a medical emergency, this can be the presentation of congenital adrenal hyperplasia, and if seen, needs to be referred urgently. Palpate the femoral pulses. If it's difficult to feel them, this may be the beginning, or this may be screening for coarctation, so please refer quickly. Look at the hips. If you cannot abduct them completely where the femur is parallel to the floor, it may mean the baby is having dislocated hips. And if when we adduct and we push it back onto the acetabulum, nothing should happen. But if you do feel it slipping out, it may mean the baby is having dislocatable hips. Either way, this baby needs an urgent ultrasound scan of the hips as well as a referral to the orthopedic surgeon. So this cannot wait. Ultrasound scan should not be done in 1 week or 2 weeks, should be done within a couple of days, and quick referral is needed. Then we look at the back, look for the sacral dimple, where the skin should be intact, look for the sacral pit. And vulval tags are common and normal and need not be worried, but it frequently worries parents. So then we put on the nappy, we go on to the head-to-toe examination, cup the head between your hands, look for the fontanelle, the suture lines. Cephalohematoma is not very uncommon. It's due to a periosteal bleed, but it's confined to the bony boundaries. It doesn't cross the midline. Parents may be worried that this can last sort of, it can stay like, points in the head. So they try to put pattu and massage it and do various things. We have to advise not to do that. That it will go away, but not tomorrow. It will be there for about 2-3 months and gradually go away. The risk is jaundice. So you have to say, if the baby turns yellow, you can review the baby again or ask them to come back. Caput is something else which you may or may not see. This is a soft tissue swelling, but it will cross the bony boundaries, and it will, of course, cross the midline. So this is just to remind ourselves that where these tissue planes are and the difference between the caput and the cephalohematoma. So we should also measure the occipitofrontal circumference at every opportunity you get. I mean, not every day, but it's important to check whether the head is growing, and please mark it in the growth chart of the baby, and also please encourage parents who are bringing children, neonates or children, to bring the growth chart and update the growth at every visit. Check the red reflex with using the ophthalmoscope. Commonly parents ask, does this mean my child can see? Unfortunately, it does not mean whether the child can see or not. We are just seeing whether there's a clear pathway from the cornea onto the retina. So what we are seeing as red is actually the retinal blood vessel. So both sides we should see red. This is normal. But on one side, if we are seeing a white reflex, that is a problem. It may mean there is a cataract. We move on to look at dysmorphic features which may signify chromosomal abnormalities. As in this case, this is a baby with Down syndrome with flat nasal bridge, or the prolonged head and low set ears, small chin. So these babies may present with difficulty in feeding, failure to thrive, different matters. But if seen, it should be referred. And it's important to also assess for cleft palate. So sometimes they may present with regurgitation of feed, or sometimes the posterior cleft palate may be missed. Then natal tooth is not that uncommon, but frequently worrying for patients, and they are worried that this will affect with breastfeeding, but it does not, because the tongue actually comes on top of the tooth, so the baby is not going to bite the mom. So we don't need to refer all patients with natal teeth, but we have to see whether it is loose or not. The problem with the natal tooth is if it is loose, it can get aspirated. So you may have to sort of shake it and see how it is. If it is loose, please do a referral to the dental surgeon and they will take it out. If not loose, you can ask the mother to come back if it becomes loose. So then we move on to look at the neck. So we look in the midline for thyroid, thyroglossal cyst, and on the sides for sternomastoid tumors. Assess the feet as well as the hands for clubfoot, as well as look at whether there are 5 toes, clinodactyly, syndactyly, polydactyly, and the same in the hands. And we should also look at limb proportions, and what you're seeing here is actually proximal limb shortening, which is like a hypochondroplasia or achondroplasia. When we look at the reflexes, there are multiple reflexes like palmar reflex, plantar reflex, where we keep our thumbs on the sole of the baby and the fingers converge when we touch the head turning to a side, sucking reflex. So any of these reflexes would ensure that the baby is having normal neurology as well as stepping reflex, and it's very important. So we don't need to really do all the primitive reflexes, just 1 or 2 would be good enough, but Moro reflex is definitely a must because it gives us lots of information. So if I just run through what I already went through, it's important to go through a neonatal examination at every contact of a neonate, please. And so there is inspection where we look at the color, symmetry, movement, and respiration, remove shirt, we auscultate, palpate abdomen, look at the umbilicus, put shirt back, remove nappy. We go through that area with genitalia, femoral pulse, hips, back, sacral dimple, anus, put nappy back, and we do a head-to-toe examination and make sure we don't miss anything. So neonatal examination, unlike a system examination, is basically a screen for a load of things. This is not looking at one system alone, and by just performing a proper neonatal examination, we are screening, and you will be able to detect a lot of signs. The second thing is when a neonate comes to you, it's important to see whether breastfeeding has been established. So all these things actually should have been done in the hospital. In our country, where 99.9% are delivering in the hospital with skilled attendants and everything. But in case there are patients who go against medical advice, maybe. So it's important, I think, for us as health professionals and for you as a GP, where they may be having, much more contact and collaboration with you to make sure that these things are being done as well. So with regard to breastfeeding, whether the baby is getting enough milk, and also does the mother need support with breastfeeding. So why are we talking about breastfeeding? I thought I'm going to take about 2-3 minutes on this, because exclusive breastfeeding up to 6 months of age and up to 12 months has been found to be the #1 intervention to reduce childhood mortality. So it's pointless talking about neonates and children if we are not going to support breastfeeding. So it has also been found to be the #1 intervention from this Lancet series. And just to highlight why we want to promote breastfeeding, because it increases intelligence, it colonizes the gut with healthy bacteria, it reduces infection over the first 2 years, malocclusion, the risk of leukemia, as well as it reduces non-communicable disease in adults. So it has lifelong effects, as well as reducing allergy and eczema. So then there are lots of dangers of giving formula feeds. So there you may be encountering patients who are saying that they cannot breastfeed effectively, or not enough milk is coming. But taking the decision to formula feed is a very serious one, and it is better to refer these patients to the hospital with a lactation center in case you are facing problems. So the most reliable indicator to know whether is breastfeeding enough, is the baby getting enough milk, is check the weight. Weight loss is normal up to 10% within the first days of life, and term babies should be regaining weight within the first 14 days, whereas the preterm babies can be allowed more time, up to about 21 days. And within this time, so there will be some weight loss maybe till day 5, 6, 7. After that, slowly, the weight will start to gain until the baby reaches the birth weight. So just to give you an example of what I mean, birth weight is 3 kilograms, and the day 3 weight is 2.9, and the weight loss would be 100 grams. So the percentage is 3.3, which means less than 5% weight loss on day 1 or day 2 would actually signify that the baby is getting adequate breast milk. So if we look at another example, a patient comes to you on day 5 who has been discharged from the hospital. So it's very important when a neonate comes to measure the weight, because that is one of the best indicators that will tell us what is actually happening with the breastfeeding, is it enough or not. So here there is a 300 gram weight loss, and if we calculate the percentage, it is a 10% loss. So here this is more than 5% loss, which shows us that the baby is not receiving adequate breast milk. So how urgent is the referral? Can you manage this in your facility, or should you send this to the hospital? So look for the signs of dehydration and do refer. So if you have the expertise to support this mother with breastfeeding, then you can try. If there are no signs of dehydration, if you think you need more training with lactation, we would be happy to help, or else you can send to a pediatrician with a lactation center. So the most reliable sign of dehydration in a neonate would be the dry mucous membranes. The reason being, some newborns have very dry skin. So anyway, their skin is a little dry. The fontanelle may be different. And lethargy, irritability may be quite subjective. So therefore, look out for dry mucous membranes. So how do you support a mother with breastfeeding? Make sure the baby is held properly. Head and neck in the straight line. Support the nape of the neck. Don't touch the back of the head. And baby should be completely turned towards the mother. Wait for the baby to open the mouth wide. So baby whose mouth is closed and sleeping should not be forced into breastfeeding, because that will ultimately lead to breast refusal, right? And when the baby does get attached, most of the areola should be inside the baby's mouth, and the mouth should be wide open, right? Why is it so important to get all the areola inside the mouth? Because that is when the nipple area will stimulate the area behind the area between the junction of the hard palate and the soft palate, and that in turn will stimulate the sucking reflex. So if that is not done and your baby is just latching on to the nipple, because a lot of people are concerned about the nipple, mother will get hurt with a cracked nipple and baby is not going to get enough milk. Why not use pacifiers and bottles with teats? Because A, there's obviously an infection risk, but in addition to that, the way that the human breast is being sucked on is quite different from the way a teat is being sucked on. A teat is being sucked on very anteriorly with the anterior gums. So this poor baby is going to get really, really confused, which is called suck confusion. So one major reason we don't. So it's really good if you can assess a breastfeed during the practice if there is an opportunity. So we look at positioning, attachment, and suckling pattern, which would be rhythmical sucks with deep sucks with pauses. The pause is for the baby to swallow the milk. So mothers misinterpret this as the baby has stopped and the baby is sleeping. They try to touch the cheek. But as I mentioned earlier, when you touch the cheek, rooting reflex gets elicited, baby turns away from the breast. Some people flick the toe. That will also upset the baby and upset the attachment. So it's important to give her the correct advice. So in hospitals, just to show you, we have a seal like this for every mother and baby. This is at Disosa Hospital. And this seal should be satisfactory in all senses with positioning, attachment, suckling pattern before we say that, breastfeeding is established before discharge. So moving on to the danger signs. So if any of these signs are seen, it is important to refer to the hospital immediately. So I'm hoping to go through them. So if there is bleeding from the umbilicus can be normal if it's just a small amount and it's sort of getting less, because it may be soon after separation. But if it's getting more and there is a substantial amount, it is important to refer because it may be a coagulopathy. Excessive crying or lethargy is always abnormal, and it's always important to refer immediately to the hospital, maybe preferably via ambulance. If you have the facilities to do a blood sugar, please do a blood sugar, and if it's less than 45, this would imply that this is symptomatic hypoglycemia, and it's fairly urgent that this child gets an IV dextrose, 10% dextrose drip. So if we have the facility, put the drip and then send to the hospital. Choking, again, always abnormal, and we need to start first aid. It's mostly due to milk aspiration. So looking inside the mouth, giving the back blows, chest thrusts, and repeating it would be very important before sending the baby on to the hospital. Again, milk aspiration, some people believe it is normal. It is not. No normal baby would aspirate milk. If the baby is aspirating milk, something is very, very wrong. So this is due to poor coordination in suck-swallow breathing, and it's not normal for a term baby to aspirate. If it's a preterm baby or a baby who we know has, diagnosed to have some neurological problem, then we know, yes, the baby is at high risk, but still, this can kill, so it is important to give the first aid and refer these babies. Do not reassure and say, ohoma tamai, kiri aspirate, kiri is pole anawa tamai babalata. It's not the case. This can kill. So this is grunting. This is a noise that comes with babies, and you can also see a recession coming on with the baby. So here what you're seeing is this baby is already on respiratory support, but this is just to show you this is what it looks like when the baby is recessing and the respiratory rate is high. So this again is a baby with suprasternal as well as subcostal recessions. So having recessions, tachypnea, grunting, all of these are signs of respiratory distress. So these are different ways how babies can present to you with different types of recessions, different types of distress with a high respiratory rate. And this is quite urgent that these babies are referred immediately because babies deteriorate very, very fast within hours. So these babies should ideally be referred to in ambulance, or if they have their own vehicle, then it can be done. So respiratory distress you need to refer, and poor respiratory effort also, the referral needs to be made. So in addition, babies can have cyanosis. This is perioral cyanosis, and in the face, there's cyanosis here on the leg. And this baby is actually a baby with central cyanosis who was having a congenital cyanotic heart disease. So if there is cyanosis, it's very important to see whether it is respiratory origin or cardiac origin. If there are respiratory signs, then it's most probably respiratory origin. We'll need antibiotics and support with that. And if there are no signs and maybe it's otherwise, well, it's cardiac origin. But either way, again, this is something, a danger sign which should be referred. So what is the normal temperature? It's between 36.5 to 37.5. And how do we assess for hypothermia? So for mothers, we ask them to check the dorsum of the foot using the back of their hand. And if they feel that the baby is cold, we can check with a thermometer. So what sort of thermometer should be used? Mercury thermometers are no longer recommended, and there's a circular telling us not to use that because of the environmental pollution. So it should be the electronic thermometer that is used, and please advise the patients how long to keep it until they hear the beep. And where should the thermometer be placed? So I know that there's a bit of confusion with regard to the neonate because even when we started training, it was the first one. But rectal temperature measuring is no longer recommended, and the thermometer should be kept under the axilla. Not in the mouth, not in the rectum, it should be in the axilla. How should the thermometer be positioned? Commonly, we position it horizontally. But if the baby wriggles, it will sort of slip out from the other end. So a better way to position the thermometer would be in a vertical sense where the bulb of the thermometer is roofed inside the axilla. So this is a baby with abnormal movements. You may or may not have noticed that one of the arms was sort of going on. So here you see it's like a cyclical movement, but it's way too regular and way too repetitive, which is again another seizure. Okay. So babies can have weird movements. But the first two movements that I showed you had sort of slower frequency, whereas this is a very rapid movement and can be stopped with the hand. So the last video was of jitteriness, whereas the first two were of seizures. So abnormal movement, we have to see whether the baby is well or baby is ill. Baby is ill, it can be an infection, a metabolic abnormality like hypoglycemia, hypocalcemia, hyponatremia, intracranial bleeding, or if the baby is well, it may be a seizure disorder. And in any sense, again, check the blood sugar, start a drip if possible if it's low, and send the baby urgently. So then looking at the eye, there is redness and inflammation, looking like a periorbital cellulitis, urgent referral for IV antibiotics. Again, this is very purulent bacterial infection, so we need to refer if there is pus, swelling, and erythema. There is some crusting around the eye, but it's only around one eye, and the eye is looking otherwise normal. So this may be a blocked tear duct. All that it needs is reassurance. And we can maybe ask the mother to massage along the duct. This is a conjunctival hemorrhage, which is common if it's seen after birth. But if it's a later occurrence, we have to see whether there's a coagulopathy or a non-accidental injury. Skin rash is quite common in babies. Some are dangerous, some are not. So all these are dangerous abnormal signs. But this, although it looks alarming, so I'm sure you know this is erythema toxicum, which is a benign rash. No need to put any cream or anything. This will go away by itself. This is a single pustule. This is multiple pustules. And this is even more horrible looking pustules, more extensive. And this is an abscess, all caused by Staphylococcus. This again is what we refer to as a stalk bite or a capillary hemangioma. Benign lesion. These are milia on the nose, again benign lesion. This again can be a capillary hemangioma or a vascular malformation. Because of the location between the eyes, we have to think of possible vascular malformation and Sturge-Weber syndrome. Better to image the brain as well as look at the eyes. These are very common in our Asian babies, Mongolian blue spots. So if it is not a benign rash like erythema toxicum or Mongolian blue spots, refer, and if not sure also please refer. So skin infection, daily baths after the first 24 hours of age, local application of fusidic acid, especially if there are less than 10 pustules. If there are more than 10 pustules, you can start a systemic antibiotic. If the baby is systemically well, you don't need to admit, you can start oral antibiotic and review the baby. But of course, if the baby is sick, urgent referral for IV antibiotics. And if there's abscess, of course, please refer for I&D as well as antibiotics. So nappy rash is not uncommon, but we have to differentiate between ammoniacal dermatitis, where the flexures are spared with no satellite lesions, with candidiasis, where the flexures are involved with satellite lesions. So the picture I showed you is actually a candidiasis where the flexures are involved with satellite lesions. Looking at the umbilicus, this is a picture with periumbilical erythema signifying systemic infection, pus. This is a healthy umbilicus, and blood. So the 3 danger signs. A common mistake is applying cream on the umbilicus and sending back. So if it's an unhealthy umbilicus, wash it and review. But if any of the danger signs are there, then you can have a better idea. So if these are persistent, please admit for IV antibiotics. And if there is persistent discharge despite good hygiene, it may be an umbilical granuloma. So this again you can treat with applying copper sulfate, but make sure you apply Vaseline on the umbilicus, otherwise there can be burns, and make sure you wash it off and have a good look before you send the patient home, otherwise there can be a sort of a circumferential burn on the abdomen. So this is again Kirimalayang in Sinhala, or this can be candidiasis or milk residue. So firmly rub it off with a piece of gauze. If there are bleeding points present, this is candidiasis. If underlying oral cavity is normal, it's milk residue. If there is jaundice, it can cause kernicterus, and all babies with jaundice needs assessment. Refer to the nearest pediatrician with a referral letter, and do check the serum bilirubin. If you have facilities to check the serum bilirubin, use the NICE guideline charts. It is there in the neonatal guidelines. But holding the baby to sunlight is not recommended, so please don't ask people to do that. If you send early, we can generally settle it with phototherapy, but if you send late, it may need exchange transfusion, very, very risky procedure, or worse still, athetoid cerebral palsy. Vomiting with bloody discharge or bile is a problem. Vomiting with poor weight gain or vomiting in a preterm should always be referred. We need to emphasize looking at the weight chart, look for poor weight gain, flattening and faltering. If they are there, again, please refer. And any mother who is concerned with regard to anything else, poor feeding, reduced activity, irritability, abnormal movement, we may not see it. It may be the mom who is complaining, but it may be safe to refer. So just to summarize what the newborn danger signs are, and just for your information, newborn guidelines are freely available on the net if you would want to refer to any of the things or any more further information. Thank you very much.
Thank you, Dr. Nishani, for that very comprehensive presentation. We can take some questions if there are any questions. In the absence of questions, I ask Dr. Arulananda to give the token of appreciation. Our next presenter is Professor Pujitha Wickramasinghe. I'm happy to introduce him. He's my good friend, batchmate, and colleague. Professor Wickramasinghe is an honorary consultant at the Led Ridgeway Hospital. He's a senior professor of pediatrics at the University of Colombo and serves as a consultant to the Ministry of Education and Ministry of Health on childhood health and education. He has published more than 125 journal articles, 200 abstracts, 8 books, and 24 book chapters regarding childhood nutrition, growth, and body composition. He was honored with the Presidential Award for Research in the years 2008, 2013, 2014, and a Lifetime Award for the most outstanding senior researcher in the field of health science in Sri Lanka universities, which amounts to 36 awards, making him a decorated academic and a clinician. Over to you, Prof. Pujitha.
I don't think anybody is in a mood to listen to a lecture now. I don't know whether there is a point of giving this lecture. No, I don't think, I don't know, because, everybody's, it's very difficult to talk to an audience. 2 hours gone, anyway. I don't know, I'm not really comfortable, sorry about that. So, fostering pediatrics, so pediatrics is all about growth and development, and there are various things which comes from a single cell going on to. So if there is no proper nutrition, but this is not the only thing, and nutrition, if it is more or less, then it will cause a lot of problems. So these are the factors that causes undernutrition issues, and these are the factors that cause overnutrition issues. So now what has happened in this country is that there is, over the last whatever period of time, malnutrition has come down but has stagnated. And then in the old age group also it has something like that, whereas in the 15 to 16-year-old age group also you can see that it's happening. So overweight obesity is a big problem, and because of that we have to address that issue. Well, obesity is a great harmer, and I think in the morning those who were, was sort of shown that how it affects the kidney diseases, diabetes, all that. And you can see in the age groups this, where when they are obese, they have a lot of metabolic problems. And overall metabolic syndrome is present about more than 20% in obese children. Right? So diabetes is also, or pre-diabetic states are starting in children from a very young age. So although diabetics was discussed in the morning, you could see that if the child is obese, even at that age, you would begin to see obesity. So the danger is more than 75% of the obese children end up as becoming obese individuals or adults, which of course is a major problem, where that is the gateway to develop many of the non-communicable diseases later on. Whereas if a child is lean, then of course it is less than 10%. Then the alarming thing is, of course, I'm not alarmed actually, because we have to die of some reason, and 83% of the deaths are due to non-communicable diseases. And if you remove the injuries, you would still say about 70% will be dying of non-communicable disease. But that is not the alarming thing. The alarming thing is that the premature deaths risk of more than 15% females and about 22% males are at risk of dying between 30 and 70 years of life. And that is also, we are far behind the WHO targets that have been set for 2025. Now, if we are to foster the future, what do we have to do? So most of the stuff that happens during the first 3 years of life determines the adult milia and how do they work. And two main theories are there: fetal origin of adult diseases and postnatal growth hypothesis, which are two major things that will be contributing to this first 1,000 days. And you all may have heard that from conception going on to the second birthday is the main things. And in this country we have shown that how it affects children, even growth at between 6 to 12 months or 18 months, how it has affected, and shows damages by 11 to 13 years of life. And even further, if they have a rapid growth later in life, they have begin to show a abnormal metabolic profile much more earlier in life. And especially children who are born with a low birth weight will have much more adverse consequences compared to the others. And now how are we going to ensure optimum growth? There are few factors. It's not only nutrition, but there are other things which, like optimum birth outcome is one of the major things. As I told you, first 1,000 days is important, and in that process you could see that birth outcome is a major problem. And initiating proper feeding practices, then growth monitoring, food marketing, physical activity, as well as creating happiness is one of the important things. Now we have to make sure that we give a good head start, and important aspect is actually not during pregnancy, looking after the adolescent girl, which comes under your purview to a great extent, and where they have to be having, because that is the last window of opportunity for a child to grow, and that should not be missed, because definitely a child who is having a good size pelvis, a good size uterus, would invariably will give a good birth to a good healthy baby. The pre-pregnancy counseling and optimization of weight, because a female going into pregnancy state in an undernourished or overnourished state or obese state is a very, very detrimental thing, because it can cause the child to be undernourished as well as obese. So during pregnancy as well as pro-pregnancy period, you have to take care of. Then feeding right. Nishani also earlier spoke about exclusive breastfeeding. Yes, that is the important thing. And then, of course, that should be followed up with proper complementary feeding and introduction of food later in life. Now, what happens is actually there is a new guideline also which has come up from WHO, which of course you can download from the site. Then exclusive breastfeeding, although I said and Nishani said up to 6 months, sometimes a very small minority of children may not be able to sustain growth till 6 months with the mother's milk. So if they don't have any other illness, then of course at 4 months of age people can start complementary feed. There is a misconception thinking that the child is not ready till 6 months. No, there is nothing like that. The child can take after 4 months, but when the breastfeeding can provide all the optimum nutrients, then of course there is no need to risk the child with introduction of other complementary food. Then 3 main meals, the 3 meals should be stuck, because sometimes when children are not eating, they are kept on giving various number of meals, and ultimately they go into a wrong feeding habit. And as a result of that, what will happen is that the child will ultimately end up with getting either obese or not getting a proper nutrition at the end of the day, because they had been keep on grazing throughout the period. Then responsive feeding is one of the most important. In today's context, most of the time what happens is that they are doing distracted feeding. And the mobile phone is one of the most endangered or the dangerous equipment today used in the household, because they are trying to feed the child by distracting. It is not feeding actually, it's just putting things into the mouth. But on the flip side of that is, you would come across many children after 1.5, 2 years still are not talking. There is a huge speech delay problem in the community, mainly induced by the mobile phone, because they have been distracted. And those who have a trait to develop autism will also end up with getting autistic behaviors, because this is well known to precipitate autism in these children. So you have to make sure that is looked after. And also supplementation programs are there in the country for low birth weight preterm babies. Till up to 2 years, iron and multivitamin are supplemented with folic acid to a certain period. And then for older children, for other children who are having a normal birth weight, will be supplemented at 6 months, 12 months, and 18 months with multiple micronutrients. So in the private sector, of course, you may not have that. So, but they also should be given iron as well as multivitamin supplementation, because that is important, because there will be the maternal stores or the stores during pregnancy, what they have gained will be dwindling, especially iron, because breast milk is not a good source of iron. And then what will happen is, when the iron deficiency sets in, they may not go into anemia, but they may have iron deficiency, then it will affect the growth as well as immunity of the child, and they get prone to more illnesses, especially if they have older siblings, because they catch that from school and come back, as well as they will have a poor appetite. Then these are some of the other things which hinders a proper feeding practices and also contribute to overnutrition as well as undernutrition. Then these are some of the food taboos, where sick children are deprived of certain food, thinking that it will be harmful. Unless there is a direct food allergy, of course it should not be taken away. Then imported foods are better. Then price is directly proportionate to the knowledge is a thought. And then taste preferences override the price and the seasonality, because we are a country which not using seasonality to the optimum. So at the end of the day, we say the prices of food commodities are expensive, because out of season things people are trying to buy because they are used only to those tastes. So that type of habits actually I think we have to inculcate in the public, because more than what main thing is that they have wrong preconceived ideas. And food preservation, which was a household thing long time ago, is not happening to a great extent today. So growth monitoring is one of the most important thing, and whenever you will plot the growth, but of course having a single point will not be very, very useful, because you could see how this child should have been growing. And if we see a single point, we will think, okay, within the normal acceptable limits, it should be normal. No, we have deprived the true potential of this child. So these are things that happen really in the community. So, but although the number 2 is in a much more danger-looking zone, they are, of course, that person had been growing very nice. And you should not stop there. So the trends are the most important thing. It is not a single point. And you can also, whenever the trends, especially if there is an upward crossing trend, always verify with the weight for length chart, because don't go by only the weight for age chart. You also have to use weight for length, or length for age or length for height chart, because that is very important. And at least once in 6 months, if you have regular follow-up patients, children, they should be plotted, and then of course refer to the weight for length chart and see whether they are in an early stage of crossing on to the overweight obesity side, or even could be underweight, because sometimes there may be a normal weight child but who is actually fairly tall for his or her age, and then it will be in a malnourished state. Then food marketing is a huge problem, because it has exploiting a lot in the community, and of course driving people into a wrong direction. And we have done some research recently also and shown how powerful the marketing and how persuasive the marketing strategies. Of course, there are today the delivery of food to the doorstep is happening, a flip side of the COVID, and more people are now using these delivery systems, and actually they don't burn even any calories even to procure the food. So this is a huge problem in the country, and there are a lot of guidelines produced internationally by the WHO, as well as now there are certain strengthening of local legislature is also coming up. So I think it's very, very important that, because ultimately the child who is not knowing anything about this get battered by the, because they are getting, the persuasion is such, marketing strategies are so forceful, unknowingly they get pushed into a wrong dietary practice. Then one of the most important thing is, because when we talk about malnutrition, always we talk about food, but malnutrition and food is not synonymous. So food is not the sole cause for malnutrition, whether it's over or under. There is another whole heap of other things. So one major important thing is the 24-hour movement, because we may talk about physical activity, but physical activity in isolation is useless. Why I say that is, somebody may be physically active for 1 or 2 hours a day, vigorous physical activity, but of course all the other time, the other 20 hours, 22 hours, if they are doing things which are unhealthy, then of course that 2 hours is no use at all. So if you look at these items, out of these, the chair is the most detrimental item or most unhealthy item that could be found in the human, utilized by the man. And you can see there is a sitting syndrome itself that has been developed. If somebody sits for more than 7 hours a day or 7.5 hours a day, that is of course fairly unhealthy. And then, so that's why the WHO came up, especially for children under 5 years, the 24-hour activity guide or the movement guide, where physical activity in isolation is not quite adequate. You also have to control or have the adequate amount of sleep, which is being deprived to a great extent in children, and most of the children are sleeping late night. That Even 2-year-old, 3-year-old goes to sleep, bed at 11 o'clock. So that is very, very unhealthy, not only from the nutritional status point of view, but even contracting and getting lowering the immunity and things like that. Then, of course, sedentary behavior. So there are guides for the amount of sleep a child should be sleeping, and actually that had been incorporated even into the CHDR, especially the sedentary behavior time, which has to be a minimum, and then the sleep time should be optimum, and all the rest of the day should be occupied by physical activity. Then, is nutrition enough? No. And physical activity? No. That's why today some people think that loss of height or short stature is not actually directly equated to malnutrition or undernutrition. So there are a lot of other things beyond nutrition which also we should be thinking of. That is, now this person is the famous director of the Fels longitudinal study, which is the longest longitudinal study that has ever been done in the world, where she says that the modern understanding of the growth, health, behavior and effectiveness of human beings could only be understood if the nature and the significance of individual characters of each child's physiological, biochemical, nutritional, educational and environment characteristics could be assessed and integrated into a total picture. So always when there is malnutrition, everybody ups in arms and say there is no food. That is not the only thing. Have we made other things conducive? There is this new concept called socio-economic, political and emotional background, SAFE phenomena. Now, where do we know? We know to the great extent whether our environments are conducive, safe, stress, minimally related environments. Because providing food alone is not going to solve the problem. So these are some of the other things which you have to look into there to make well-being. Otherwise, you will never be able to. So that may be one reason why undernutrition has come and stagnated at 15% or so in this country for the last 25 years. Undernutrition is like that. It has got stagnated and people are doing this program, that program, but all are nutrition related. But people are not looking at the other socio-political, cultural aspects and making a conducive, child-friendly environment. And that's why has been shown even same age children who are coming from higher shape categories are taller compared to those who are having a poor shape background. So this is of course not directly related to a child, but of course to the growth or nutrition, but of course this is something again we have to be alert of, where the WHO has put out this, recognized this adverse child effect, which would be adversely affecting these 10 factors, which of course we have to also subtly look into the family dynamics and find out and then correct, or at least attempt to correct these things to as much as possible in order to achieve the best growth. So child growth and health depends beyond providing nutrition, but many more where we have responsibility to ensure creating a conducive environment. That's the investment actually we could do to the future. Thank you.
Thank you very much for the informative and comprehensive message on child growth. I call upon Dr. Asele to, any question please? In absence of question, I call upon Dr. Asele to hand over the token of appreciation.
Thank you very much, sir, and kindly request the chairpersons to give away the token of appreciation to Professor Pujitha Wickramasinghe.